If we go back to our case, we want to apply what we've learned to it. So we want to hear more about the risk factors in this case, which we'd ask about. Let's say that there's some prom of 25 hours. Find out if there are any other symptoms other than the ones that have already been mentioned. So we've already got enough to work on here. We've got poor feeding, we've got low temperature, we've got an irritable baby with a changed conscious state. These are all, and plus we've got one risk factor. This is enough definitely to treat this child with antibiotics. In fact, the fact that they've come in with respiratory distress and they don't look well to you, I would treat this child urgently for sepsis. But as you're examining them, and I'd like to say you should probably get someone to try and start the blood taking and cannula process whilst you finish examining the baby. You want to get your seniors involved very quickly here. But whilst you're examining them, you do want to check things like pulses, because if their pulses are absent, it changes your diagnoses to more cardiac things. You obviously want to check for fontanelle, see if there's any signs of rash, because if you're pointing yourself towards meningococcal sepsis, then again that might change your length of treatment if nothing else, and certainly you want to be pointed towards whether you're going to treat this as meningitis. If the baby has convincing features like this one does, then you really should do a full septic screen and a gas as quickly as possible. This child, it's likely neonatal sepsis. It might not be, it might be nothing, but you have to treat it as neonatal sepsis until proven otherwise. As far as treating sepsis goes, there's technically slightly different guidelines depending on whether it's the first 72 hours of life, i.e. just after they've been born, or whether they've gone home and come back, and it's a bit later than that, but really they come down to a very similar thing. So essentially, if you've got one risk factor or a symptom, then you observe. If you've got two or a red flag, then you treat. So most centres will give antibiotics to mothers if they've got GBS or PROM intrapartum, and you then don't have to treat that as a septic risk factor. There are a few places that do give IM penicillin to babies that just have GBS in the mother, for example, but that's not really treatment. If you do decide that you are treating, then what you do is you put in a cannula, you send a CRP, an FBC and a blood culture and start IV antibiotics, and pretty much that's always BenPen and Gent, because that's the adequate cover for the likely pathogens. If there's a strong suspicion of infection, so it's not just risk factors, the child's symptomatic, and you think that infection really is something to consider, then you really should do an LP. Ideally, that should be pre-antibiotics, but almost always it happens fairly soon after the first dose because you want to get the first dose in for protection. If you get a very high CRP or you get a positive blood culture, and then you definitely should, then we also do LPs. You don't need urine microscopy in the set of patients who haven't gone home. That's the main difference between the two treatment strategies. You can add in antibiotics if they're not really responding, and generally we repeat a CRP at 18 to 36 hours because that tells you how long you're going to treat for. So if the child's well, the blood culture is negative at 36 hours and they've had 2 low CRPs, you can stop antibiotics. If they're unwell or they've had a high CRP or a positive blood culture for most things, then you give 7 days. And if you suspect or you prove meningitis, then you give 2 weeks or 3 weeks if it's an E. coli. And the main differences here, if they come out after they've kind of gone home and they come back in, then you kind of look a bit more under the fever in the under 3-month-old, which is kind of a sepsis system that NICE has created. It ends up being very similar. You still have to take risk factors into account. You observe the child, and essentially if they're less than 1 month old and they've come in symptomatic, and so you think that they've got signs of sepsis rather than just risk factors, they will also get a lumbar puncture. And now they should get a urine dip as well, because the pathogen profile, once you're more than 3 days old, is less likely to be GBS sepsis, more likely to be other things, and so you want to rule out a urine infection. Personally, I'd always do a gas just to get things like a lactate and to look at other differentials, and also LFTs in this age group, because jaundice often comes with sepsis as well. If you can do a lumbar puncture pre-antibiotics, it'd be great, but in reality that often doesn't happen. You don't need to x-ray these children unless they have got specific chest signs that make you think that a pneumonia might be there, and even then I would discuss with a senior before x-raying any children coming in at this age. Obviously, if they're having seizures, you may well have herpes simplex, so you think about putting in acyclovir because that can cause an encephalitic picture. And antibiotics now slightly change, so you give a third class cyclosporin, cefotaxime usually, because in this age group we don't tend to use ceftriaxone, and you give amoxicillin, which covers for listeria, and you can give a bolus if you need to, obviously being aware of the risk of myocarditis, but essentially what you want to do, assess as quickly as possible, get your senior involved, take your bloods and your culture, give IV antibiotics, then get an LP in the urine. This is the nice traffic light system. So this applies to all children under the age of 5. As you can see, there are specific bits that apply to the under 3-month-olds. The thing that is specific to neonates and not to older children is that you do a lumbar puncture if they're kind of getting red on any system of this. So we do LPs because it's very hard to rule out meningitis, and because it really does change your management in terms of length of treatment and nothing else. Just want to briefly mention delayed onset GBS sepsis as well. So this is something you get after 7 days. It can be up to 3 months. The mortality is less, and it is also less common. So about 2/3 of GBS sepsis are early onset, and it's a completely different mechanism of transmission. The main thing to bear in mind here is that if you've been treated for early onset GBS, that does not mean that you can't get late onset GBS, and it does not increase your risk of getting it either. So don't be falsely reassured or falsely worried by someone who has had early onset GBS or GBS colonization of the mother at the beginning. Once you get past 7 days, it's a completely different set of factors. And in this kind of child, sepsis is the thing that we will be treating. We want to make sure we've thought about these other diagnoses as well. So meningitis, we've mentioned, and that's why we LP very, very easily. But the other key thing that we need to know is if there is a meningitis, then it can affect hearing, so we always arrange audiology follow-up. Urinary tract infections, so if they're not straight immediately after birth, then we always do a urine dip. If we confirm a UTI, then you get a renal ultrasound to make sure that there's no underlying pathology anatomically or vesicular reflux. That is a reason for the UTI occurring. You have to think about possible viral infections. So bronchiolitis is very common in the slightly older part of the neonatal age group. Think about myocarditis. So the important thing here is if you chuck boluses in too quickly in a myocarditis, then they've not got effective ventricular function, and essentially you can overload them and make them very sick. So we'll talk about that in a second. Metabolic disease is something that is worth thinking about, especially if it's early onset, and if you've got a very high lactate and a very low sugar, you should consider it. So the gas is kind of to reassure us regarding metabolic disease. If the heart rate's very high, consider an SVT. What you should do is get an ECG, see if you can find any evidence of SVT on there. You can try vasal manoeuvres, which for this age group basically is ice on the face. And then if that's not working, then you give adenosine, trying to capture the moment when you stop the rhythm. Congenital heart disease, as we said, can present this way, so that's why it's very useful to get your pulses and to make sure that there's no cyanosis. So that would be in the first few days of life. And some surgical issues can present this way, particularly neck in the first few days, especially if they're ex-preterm. This one too, if you think that they've got bilious vomiting, then you should always get the surgeons involved. That's kind of your red flag for surgical issues. Just to talk about the myocarditis briefly, the things that would tell you that there might be myocarditis there are if you can feel very muffled heart sounds, or there's a persistent tachycardia that doesn't really fit in with the degree of fever and doesn't respond. Those are big red flags as well.